Hi and welcome to the lecture on gout. My name's Matt Dilnot, as you probably know, and you'll probably also know that gout is one of those conditions which primarily affects the foot, and therefore it's relatively important for podiatrists to recognise this condition when it presents in the clinical situation. So just to give a brief overview of gout, it's important to remember that gout is a relatively acute, or typically acute, monoarticular arthritis, so it affects principally or presents as a one joint problem, and it's traditionally known, as you probably know, to affect the big toe joint, particularly the first MTPJ. Its presentation is typically sudden, severe pain. Quite often the patient will be surprised that they've got pain because they can't remember hurting the joint, and that's particularly if it's the first presentation. So if someone's never suffered gout before, and they may be surprised and they don't know what's going on with their foot. So typically the pain is severe. People often rate it as a 8 or 9 or even 10 out of 10 pain. It stops them from sleeping. Typically the joint is swollen, it is red, and it is typically, because of that inflammation, warm to touch. And quite often I will get a digital thermometer to assess the temperature of the joint, and normally it will be around about 5 or 6 degrees warmer than the contralateral side. So when it affects the big toe joint, it is typically known as podagra, and you'll see this in the literature. And if you're interested to know what podagra actually means, it means foot grabber, and it comes from ancient Greek. Gout comes, the word gout comes from Latin gutta, which means drop. So this relates to the fact that this disease appeared in the early days as though it was dropping to the foot primarily, and hence the name gout. Gout is one of the earliest diseases to be documented, and was first identified by ancient Egyptians as early as 2640 BC. So let's talk about the triggers and causes of gout. The essence of gout is around uric acid, and we'll discuss a little bit more about that in detail soon. So uric acid is at the centre of the disease, and it ultimately is around elevated uric acid levels in the blood. So this is typically caused by a genetic predisposition. Traditionally, if you look at the literature, people have blamed diet as the principal cause, but over the last 10 years we now know that gout is primarily caused by genetic changes or inheritance. Now, in addition to that, though, gout can be triggered by trauma. So stubbing your big toe, for example, wearing different shoes, participating in activities which cause irritation to the joint can actually trigger off the attack of gout. Dehydration can also increase that. Now, dehydration can occur because of alcohol consumption. It could occur, of course, because of increased sweating and activity, and it can also be caused or triggered by dietary changes, and normally quite significant dietary changes. So it could be an increase in alcohol consumption, for example. It could be a sudden increase over a number of weeks or months of certain foods, particularly shellfish and organ meats. And illness is certainly another trigger. So if you have an illness which tends to be pro-inflammatory, it can often trigger the gout attack. Now, one of the key things to learn here is that the gout which appears hasn't just suddenly appeared from nowhere. It's typically uric acid accumulating in joints or in tissues, which has happened over years and years, and we'll talk about that a little bit later. In addition to acute gout, we can also talk about chronic gout. And chronic gout is the development of tophi. So as you can see in this picture here, there is a white mark near the fingernail, and that is a tophus. And this is a collection of monosodium urate crystals. Just as an aside, these can ulcerate, and when they ulcerate, you can actually see the monosodium urate quite easily as it's exposed under the skin, and those crystals can actually be flicked out or removed using the tip of a scalpel. So when we develop tophaceous gout, which is chronic gout with that build-up of monosodium urate crystals in the tissues, this can cause long-term joint damage and disability to joints if it's occurring within the joints themselves. Sometimes they'll form in the ears and sometimes around other parts of the body, and commonly you'll see them around the distal interphalangeal joints of the toes. We tend not to see them as often these days because gout is probably better managed than it used to be, but you will still occasionally see people with chronic tophaceous gout. So we'll move on. So just a very quick overview, we'll go into this a little bit more detail soon. We want to know where the uric acid comes from, and essentially uric acid comes from the breakdown of DNA and RNA. So DNA and RNA in all of the cells that are digested have in between them something called purines, which forms part of your chromosomes. So when cells are broken down, the DNA and RNA is broken down into purines, and then purines are broken down into uric acid. Now that uric acid floats around in your bloodstream, and some of it might be excreted, a lot of it isn't, and a lot of that uric acid may start to seep into the tissues. That includes the soft tissues, the muscles, the tendons, skin, and particularly joints. When uric acid seeps into soft tissues, it can, in higher concentrations and with the correct pH and in the presence of sodium, connect with the sodium, and then it forms monosodium urate. So monosodium urate is the substance that people typically refer to inside joints, which is the form which tends to crystallize. So again, we are breaking down DNA and RNA from various tissues into their components of purines. That then gets broken down into uric acid, and then uric acid, when it floats into the tissues, can attach to sodium and form monosodium urate, which can then crystallize. So let's go into this a bit more detail again. So uric acid production comes from purine metabolism, as I've just said, and the purines come from DNA and RNA. So I've just drawn, or have a little picture up here of a chromosome, and in between that you will see the links of purines. And there are 4 purines that are involved in making chromosome DNA and involved in RNA. Now, what you may or may not realize is that a lot of what you digest every day is actually yourself. So you're primarily digesting your own broken down cells from your stomach lining and from mucus, and that goes through your intestinal wall, and that DNA from your own cells, as well as from food that you ingest, is broken down into the purines. And that's broken down by something called xanthine oxidase. And so when xanthine oxidase breaks down purines into xanthine, it is then broken down even further into uric acid, and that's where it typically finishes. So uric acid then is the remaining metabolite which floats around in your system, and you can develop gout from having too much of that. Now, when we look at other animals, most other animals, particularly mammals, have something called uricase. And uricase is something that breaks down uric acid into allantoin. But we don't have that enzyme anymore. So, and we'll talk about that in a little bit. So, going back to our source of uric acid, it comes from both endogenous, which is yourself, and exogenous purines. But most purines come from yourself, not from what you eat. So some foods are higher in purines, however. So organ meats, such as liver and kidney, have higher amounts of purines in them. And fish and shellfish has higher amounts of purines. And beer and certain spirits have high purines because they are created using yeast. And when you use the yeast to make alcohol, that yeast can be broken down. There's lots of yeast used to produce beer, for example, and so beer has a high purine content in it. But alcohol also can dehydrate you, so it's not just the purines in the alcohol. Alcohol itself can cause dehydration, and that in itself can trigger off potentially a gout attack rather than just being the purine content. So going to go on a little bit further into the biochemistry of this. So uric acid, as I've said before, comes from purine metabolism. And hyperuricemia, basically when you have too much uric acid, and this is defined as serum uric acid levels greater than 6.8 milligrams per deciliter. You can convert this to 0.356 millimoles per litre. And it's useful to remember these numbers or be aware of these numbers when it comes to diagnosis and choosing medications. So let's talk about crystal formation. Crystal formation can be triggered by factors like reduced temperature and pH in peripheral joints. And this is one of the theories that they have as to why gout tends to develop more in the periphery, because the toes experience a lower temperature than the more proximal joints, and that they believe helps to contribute to an increased chance of developing monosodium urate crystals. The pH in the peripheral joints can also be altered, and this is particularly in the case when joints are inflamed, and the pH can change as a consequence of that. So when you have a slightly arthritic big toe joint that is getting trauma to it, it can develop swelling and inflammation, and this changes the pH, and that, if you have high uric acid levels, can lead to the development of monosodium urate in the joint. So uric acid reacts with sodium ions to form the monosodium urate we spoke of before, and this leads to monosodium urate crystal deposition. Now I've got what looks to be a complicated chart here of uric acid processing, but I just want to go over this again. We've got different types of purines, and they are converted into hypoxanthine, xanthine, and then uric acid. Now if you had uricase, you would then break that uric acid down into allantoin, but we do not have that. So most other mammals outside of primates have it. Some fish have other enzymes as well, and some amphibians have other enzymes in addition to that. So we have lost this ability to break uric acid down, and there's probably some good reasons why. So we've alluded to the fact that different tissues or different foods have higher amounts of purines in them. So foods with high cell density or rapid turnover, such as organ meats and seafood, contain elevated purine levels. So yeast used in fermentation also has a high purine content due to its rapid replication. So this is obviously used in beer manufacture. Plant-based foods like spinach and mushrooms do contain purines, but their bioavailability and metabolic impact on uric acid levels are lower than those from animal sources. So typically, if we're going to develop gout, it's probably going to come, if it is related to food, and it's becoming less and less related to food these days because of our improved knowledge of genetics, and it's going to come from these types of foods. So I just find it interesting just to talk about protein and purine metabolism. So just to reinforce this fact, approximately 70 to 80% of the protein absorbed through your gut is actually derived from yourself. It doesn't come from the food you're eating, it's coming from breaking yourself down. So you're shedding off the lining of your stomach, you have mucus going into your stomach, and that contains cells which are then broken down, and interestingly it gets recycled. So you can recycle the protein and you can actually recycle the purines, and the uric acid can be used again. So only 20 to 30% of protein absorption comes from dietary sources. So the gut is very efficient at recycling endogenous proteins. So we can convert that. So around 2/3 of metabolized purines come from yourself, and 1/3 of purines come from external sources like food and drink. Now, there are some potential reasons why we have lost the enzyme uricase. There has been lots of discussion over the last 30 years trying to work out why we actually have lost the ability to break down uric acid, and we wonder whether it is actually a beneficial thing. So uric acid acts as a powerful antioxidant. So this helps to neutralize free radicals which come from metabolizing of other foods, and protects cells from oxidative damage. So it is probably in total the most powerful antioxidant in your blood. The opposite to this, however, is if you start to experience hyperuricemia, this can actually cause a pro-oxidant effect. So this can actually become damaging. So there is a sweet spot there between having enough uric acid for its protective aspect and then also having too much. And if you have too much, this can lead to things like hypertension, obviously gout, and cardiovascular dysfunction. So when you're looking at your blood being cleaned by your kidneys, uric acid goes into the tubule, it goes to the glomerulus, into the tubule, and roughly about 90% of the uric acid that is actually filtered out of the blood is reabsorbed. So you're actually trying to suck it back in to maintain your uric acid levels. And only 10% of the uric acid that goes into your renal tubules is actually excreted. And there's about one third of uric acid is excreted through your gut. So 2/3 is actually excreted through the kidneys, and 1/3 through the gut. But just remember that 90% of uric acid is reabsorbed in the kidneys. Now, this does help you to understand that if your kidneys are not functioning well, you may actually have problems with either excreting or reabsorbing uric acid. And typically when your kidney function starts to go downhill, especially as you get older, you may start to get higher and higher levels of uric acid because it's not even excreted into the tubule itself. So the aging process and kidney abnormalities can really cause problems for uric acid levels in the body. So we've talked about the fact that uric acid accumulates in the body. So you don't develop your gout overnight. You don't develop gout over a few days or a week. Uric acid accumulates over years. And so they've roughly looked at the time it takes for the average person to develop a gout attack after having hyperuricemia or high levels of gout. And they've worked out it's approximately 10 to 12 years from the time you start to accumulate uric acid to the time that you develop your first gout attack is a long time. It's about 10 to 12 years on average. Now, obviously, if you have significant hyperuricemia, then you are going to develop gout faster than someone who has just a little bit of your hyperuricemia. So you may just go over that level now and again, and therefore you may never develop gout in your life. And contrary to that, someone has very high amounts of uric acid are much more likely to get gout. So in one of the interesting studies from the 1960s, the Framingham study, which was a very significant study, showed that in men who had greater than 7 milligrams per deciliter, they had about a 1.9% chance of gout. But if you're over 8 milligrams per deciliter, to 8 to 8.9, you had a 25% chance. If you're over 9 milligrams per deciliter, you had a 90% chance of developing gout. So we know that when you have very high uric acid levels for a period of time, your chances of getting gout are actually quite high. However, this is an important point, having a hyperuricemia by itself is not a one-to-one correlation. So most people who have hyperuricemia do not develop gout. It's typically only those with extreme levels for prolonged periods of time. So in order to diagnose gout, we have various ways of testing for it. The gold standard, and probably the most important thing to remember, is that in order to diagnose gout, you should ideally extract some synovial fluid from the joint and look at it under a microscope to identify the monosodium urate crystals. So that is the gold standard. Now there are some issues with that, because when you have a sore inflamed joint, typically most people do not like you sticking a needle into the joint to aspirate the synovial fluid. Now obviously you can give a local anaesthetic, but it is actually uncomfortable and sometimes difficult to get a clear extraction of synovial fluid from the joint, but remains the gold standard. We can do blood tests, and obviously if your serum uric acid levels are above 6.8, that's an indication that it may be gout. Again, we know that a lot of people, or most people with hyperuricemia, don't develop gout unless it's in the extreme range. And of course uric acid levels do fluctuate from day to day, so just because you have a normal uric acid level in your blood doesn't necessarily prove or disprove that it's actually gout. As I've said, most people with hyperuricemia do not develop gout. The clinical signs are pretty obvious with gout. The swelling, the heat, and the joint, particularly the first MTPJ, are particularly strong giveaways that it's gout. And quite likely you may see patients who have already been diagnosed with gout, and so therefore quite often the patient is aware that it's probably gout in the first place. Now you can do imaging, and there is a new type of imaging, or relatively new. It's been around for a while in research, but it's now becoming available in a clinical situation, and that's called a dual energy CT scan. And dual energy CT scans are wonderful things because, as you can see on this picture here, it will actually show up the monosodium urate around the joints. Wherever it's deposited in the foot, it'll show up. So dual energy CT scans are actually pretty good things to use if you're trying to diagnose gout, and also just to see the extent that the monosodium urate has developed in the foot. You can also use an ultrasound, and that will particularly look for something called the double contour sign, which I'll show you in a second. The differential diagnosis for gout is that we do need to be aware that some people may develop septic arthritis, and that can occur spontaneously. Again, can be red, hot and swollen. So again, important that we don't just jump to the conclusion of gout for all red, hot, swollen joints. So septic arthritis is clearly going to be a differential diagnosis. Again, a synovial fluid analysis would differentiate the two. Rheumatoid arthritis can, on occasion, sometimes present as a a monoarticular joint problem. And there is also something called pseudo-gout, which is actually more common than we often realise, which is calcium pyrophosphate deposition. Now, this doesn't typically cause the same level of inflammation as gout, and it doesn't show up on imaging, of course, in the same way that gout would. And there is, of course, the osteoarthritis case where you might have something like hallux rigidus or limitus, which becomes inflamed. So it can be difficult in mild cases of gout to differentiate between osteoarthritis and gout. In addition, on x-rays, if you've had long-standing tophi and inflammation, you can start to get rat bite lesions around the joint where the inflammation starts to invade or destroy the articular margins. So the double contour sign, you can see in this imaging here that when they look at the surface of the joint, that there's this interesting sign called the double contour sign where you actually get two lines, which is the monosodium urate, lining the surface of the cartilage. And so that is a fairly classic sign. So do remember to use an ultrasound or referral for ultrasound if you want to avoid doing aspiration of the joint. Let's talk about epidemiology. So the rates of gout are increasing globally, and there's a number of reasons why this is the case. So in the US, it's certainly increasing more, and I'm going to comment on that in a second. Most countries have around about 1 to 2% of the population suffering from gout. Now, if you look at the ratio of male to female, it's around about 20 to 1. So primarily gout is going to affect males far more than females. So again, when you have that patient who comes in with monoarticular inflammation, if they're female, you're more likely to question the diagnosis of gout because it really does affect females less often. The rates of gout are also higher in developed countries, and now this is not just to the fact that we have bad diets, because again, we have assumed in the past that it's all about bad diets, but particularly what it is actually an aging population. So the longer you live, the more time you have to accumulate uric acid. The longer you live, the more time you have to have degeneration of your kidneys, particularly if you have other diseases. And if you have other diseases, which we generally lump into lifestyle factors such as obesity and diabetes, which can also increase inflammation and also cause damage to the kidneys, then that can also predispose you towards gout. Now, there are certain foods that are known to trigger higher rates of gout. And one of them particularly that I want to draw your attention to is something called high fructose corn syrup. Now, we don't tend to have this in Australia, so most things are not sweetened with high fructose corn syrup in Australia. We tend to sweeten things with cane sugar. In America, where they have high plantations of corn, one of the waste products of corn is used and broken down to produce high fructose corn syrup, and this is used to sweeten a lot of soft drinks in the US. Now, it may seem strange talking about fructose because fructose does not have high purines in it, but it actually has an effect on your liver, which causes your liver to produce a lot of purines as a consequence of breaking down the fructose itself. Now, in addition to that, there has been a note that certain artificial sweeteners also change the way your kidneys function, and that in itself can change the way you excrete uric acid. So it would be said that the US are particularly prone to developing gout because they have lifestyle issues, high rates of diabetes, they have high fructose corn syrup, they also have high consumption of artificially sweetened drinks. So they have a perfect combination, in combination with obesity, of course, and that often leads to metabolic syndromes. That they have a great combination there that's going to predispose them towards developing gout. So when we look at the fact that gout occurs in men so much higher than in women, of course, when we look at that 3.9% prevalence in the US, that's not evenly distributed between men and women. You're going to find that prevalence of gout is going to be much higher in the men than in the women, and therefore the rates of gout are going to be much higher generally. So the global burden of gout includes a prevalence of around about 3 to 6% in men and 1 to 3% in women. Now, women do have something called a catch-up phase. Now, the catch-up phase is after menopause. Estrogen does protect against the production of monosodium urate formation. And once you pass menopause, the rate of monosodium urate increases. Now, in addition to that, if you have hypertension as a female and you're put onto thiazide diuretics, this can also increase your uric acid levels. So the combination of being postmenopausal plus using thiazide diuretics can increase your risk of gout in postmenopausal women. So in addition to that, we do know that certain populations have higher rates of gout, and they are the native Hawaiians, Black Americans, Japanese, and Maori populations. And we know that there is a strong reason for this because of the genes that they have inherited. So the risk factors for gout, as we've said, age, definitely, obesity, we've talked about, high purine diets, partly, alcohol consumption, partly, and metabolic syndrome, partly, but is rare in premenopausal women and children, of course. So most individuals with hyperuricemia do not develop gout. So you will find people that have actually got monosodium urate crystals in their joints, but they're also not reacting to those MSU crystals. And that is part of the reason why genetics plays a part here. Genetics plays a part in not only causing you to retain uric acid in higher levels, but it also changes the way you respond to the monosodium urate crystals as well. So it's a combination of factors which can increase your chance of developing gout. Now, I'm not going to go into this in any more detail here, other than to say that macrophages try to absorb the urate crystal in the joints, and that activates something called the NLRP3 inflammasome. Let's not talk about it in great detail, but it is certainly something that is being targeted when it comes to gout medication. So once again, we're going to talk about the evolutionary perspective on gout. So roughly about 8 to 20 million years ago, we lost uricase. So that means basically, now humans were not around 8 to 20 million years ago, but obviously primates were. And so roughly 8 to 20 million years ago, we lost that ability to break uric acid down. And so a lot of mammals still have it, but we unfortunately don't. So as I've mentioned, the renal tubules reabsorb most uric acid filtered in the glomerulus. Now this results in 5 to 10 times higher concentrations of serum uric acid in humans than those in other mammals. So you can see why we're predisposed towards developing gout. There is a belief, although we're not entirely sure, that elevated uric acid levels may have actually been helpful for us because it does act as a powerful antioxidant, so it helps to protect our DNA and general oxidative damage. Our diets are actually very high in calories relative to a lot of other animals. And when you have a high calorie diet, you tend to produce a lot more free radicals, and they need to be sponged up by antioxidants. So having high uric acid levels is probably helpful and protective for us and reduces our risks of cancers and so forth. It may have also played a role in enhancing cognitive function by maintaining high blood pressure. So uric acid, when it goes into the smooth muscles of arteries, can cause them to increase their tension, which helps to maintain your blood pressure, particularly in cases where you're, strangely enough, got limited water intake. It can help to maintain your blood pressure, and that helps to maintain perfusion through the brain. And of course, we didn't live as long many years ago, thousands of years ago, and so you didn't have as much time to develop gout and have the consequences of hyperuricemia. So I'm just going to talk about the Maori, sometimes pronounced Maori, population in New Zealand. So originally the gout in the Maori population was attributed to dietary changes following European colonisation. They felt that when the Europeans arrived in New Zealand roughly about 800 years ago and introduced their new Western diet, if you like, or the European diet, as well as higher amounts of alcohol, they felt that this must have caused high gout in the Maori population. But now, since they've looked back in through archaeological evidence, they've actually discovered that the Maori population was experiencing high levels of gout way before the Europeans arrived. And we now know that they have a genetic predisposition to storing, if you like, more uric acid than Europeans, and so they tend to get higher amounts of gout. So they believe that genetic aspect is so powerful that diet probably either contributes nothing to their gout, or perhaps at the most maybe 10% of the risk for gout. So increasing gout rates, as I've already mentioned, we've got rising rates of obesity and metabolic syndrome, we've got ageing populations and declining renal function as a consequence of diabetes and other things such as diuretics. And then we've also got increased consumption of sugar-sweetened beverages in the US with fructose. So there's a number of factors which potentially leads to increased rates of gout. So let's get on to the management of gout. So typically in the acute stage, when a patient presents to you in clinic with a sore inflamed toe, generally the way to go in most cases is going to be either a non-steroidal or corticosteroids, and we're going to talk about that in just a moment. The other drug that can be prescribed, and as an endorsed podiatrist you can prescribe this, is you can prescribe colchicine. So it's worth, if you can, spending some time looking up how colchicine works. Essentially, it is a chemotherapy agent, and it works by inhibiting microtubule polymerization. Now, if you don't know what microtubules are, they are essentially the skeleton inside your cells, which helps to hold them up and hold their structure, and they're also used to transport chemicals around your cells. And colchicine basically blocks the formation of that internal skeleton of the cells, and it works very rapidly, and by doing so it actually slows down or changes the deposition of inflammatory chemicals, and so it helps to suppress the gout. It also blocks the activation of that inflammasome that we talked about before. So colchicine is an interesting drug. It's one of the oldest drugs that we know of. It's been used for thousands of years now. It comes from a plant. So it is an interesting drug, and as an endorsed podiatrist, as I say, you do have the right to prescribe it, and it's basically 3 tablets you can prescribe. Now, the mainstay of management of gout over the longer term are basically 2 drugs. So the one that you're going to hear mostly is allopurinol, and the way allopurinol works is by inhibiting xanthine oxidase. And if you go back to those original flowcharts I showed you before, when we break down purines, we use xanthine oxidase, an enzyme, to break it down into uric acid. If we give someone allopurinol, that is a xanthine oxidase inhibitor. In other words, it inhibits the enzyme which breaks the purines into uric acid. So what happens then is that the allopurinol causes you to not break them down, and therefore you will start to excrete purines rather than uric acid. Now, in some people, they can develop something called allopurinol hypersensitivity syndrome, which is not particularly pleasant. It can be cause hospitalization. So some people are not suited to taking allopurinol. So there is another drug that they can take, which is called febuxostat. Now, that's a newer alternative to allopurinol. It's similar, has a similar function to allopurinol, but it does increase the risk of cardiovascular disease, unfortunately, but it also avoids the issue of allopurinol hypersensitivity syndrome. So both of them have their complications. Generally, allopurinol is the one that most people are going to be using. Now, we need to make a special mention of another drug called Krystexxa. Now, Krystexxa, otherwise known as pegloticase, and pegloticase is a recombinant enzyme that mimics uricase. So in other words, they've developed a drug that mimics that enzyme that older mammals have, which can break uric acid down into lantoin. And allantoin is more soluble and easily excreted, and therefore you would think that this is a wonderful drug. Now, the problem with pegloticase is that it is foreign to the body, and so the body recognises the fact that it's a foreign substance and can cause quite considerable side effects because it causes an immune response to that drug. So you have a high risk of severe side effects. So 1 in 4 people have severe side effects to it. It is given as an infusion, and so when you have that reaction, it can make you quite sick. In addition to that, it mobilizes your monosodium urate crystals. So in other words, it breaks them down and makes them go into uric acid. So that in itself can cause inflammation because you've suddenly got significant levels of uric acid in your system because you're actually breaking down the deposits of monosodium urate in your system. Now, this is a key thing to remember. When you have your hyperuricemia, you are accumulating uric acid for years, and when you take allopurinol, it does not get rid of your monosodium urate. All it does is it helps to stop the continued accumulation of uric acid. So when you take pegloticase, it actually helps to get rid of the stored uric acid in the form of monosodium urate. So in this dual energy CT scan that I showed you before, we can see on the left here that there is crystals formed around the joints, and then after 6 months of taking this drug, you can see that the crystals have actually been cleared. So this is quite a powerful and exciting drug, except for the fact that it obviously has quite significant side effects. So for people who have basically gout, which cannot be managed adequately by allopurinol or colchicine or anti-inflammatories or steroids, then pegloticase or Krystexxa, the brand name, is probably going to be an okay option for them. And quality of life is going to be quite bad if you have constant gout. So for endorsed podiatrists, which is who you're going to be, there are basically some recommended steps for managing acute gout, which is essentially corticosteroid injections. Now, there are a lot of patients who are not going to be particularly happy with you injecting steroids into an inflamed joint, even if you give them a local anaesthetic, but it is probably your preferred first step. The next step from there is using non-steroidal anti-inflammatory drugs, and then of course, as I mentioned, you can give them colchicine tablets, which is 3 tablets. For GPs who are managing chronic gout, there is a treat to target approach, and this is all based on the current therapeutic guidelines, which was revised in 2024. So patients with TOFI, they're looking at trying to get their levels below 0.30 millimoles per litre, and patients without TOFI, we're trying to get it below 0.36 millimoles. So that's using typically allopurinol. Obviously there is an emphasis on patient education and making sure they adhere to the program, and you need to regularly measure their serum uric acid levels to monitor how they're going. So just some general comments on uric acid. Uric acid levels are tied through correlation and causation to a myriad of diseases. So high uric acid levels can be associated with kidney disease, and kidney disease, of course, can be associated with high uric acid levels. So they tend to work together. Uric acid can cause kidney damage, and kidney damage can cause high uric acid levels. So there is a strong correlation between the two. Hypertension is associated with hyperuricemia, cardiovascular disease the same, diabetes mellitus because of the metabolic syndrome, plus because of kidney function changes, can also be associated with hyperuricemia. And interestingly, low uric acid levels have been associated with a variety of neurological diseases. So strangely enough, diseases like some forms of dementia and Parkinson's have been associated with having low levels of uric acid. So in conclusion, gout is mostly a manageable condition with appropriate care. Early diagnosis and adherence to guidelines are essential for effective management. And integration of pharmacological treatments and lifestyle changes significantly improves patient outcomes. So hopefully that's given you a good overview, and hopefully I haven't left anything out. Thank you.